introduce L.J. Tan. Dr. Tan is the Chief Strategy Officer for the Immunization Action Coalition, where he leads the IAC's new strategic direction on national immunization advocacy and policy development. Previously, Dr. Tan served as the Director of Medicine and Public Health at the AMA for 15 years. He was recently elected onto the National Quality Forum's Adult Immunizations Expert Committee, the European Society of Clinical Microbiology and Infectious Diseases Vaccine Study Group, and serves as an editor for BMC Infectious Diseases and Medscape Infectious Diseases. He also serves on the National Vaccine Advisory Committee, the HPV group, the Vaccine Confidence, and the Maternal Advisory Immunization Working Groups. Dr. Tan has served as a member of the Federal Advisory Committee for Immunization Practices and still serves on the ACA Adult Immunization Working Group. He co-founded with the CDC and NVPO and currently co-chairs the National Adult Influenza Immunization Summit, and I had the pleasure of meeting him this summer at the summit in Atlanta. He founded and organized the first National Immunization Congress in 2007 and organized the second National Immunization Congress in 2010. I know you'll enjoy listening to Dr. L.J. Tan. Thanks, Bob.
For those of you that are standing in the back, Dr. Tan will make this same presentation right after this at 11. So if you want to go someplace else and then come back and hear him make it a second time.
I would be happy to do that, and that's what I'm planning.
I have the Q&A down to 5 minutes.
Okay.
Okay.
I won't tell them what you just said there. No, so please, for those of you in the back, I have to say, Christine Vara is giving a great social media talk next door. I love her dearly. So, if you want to go over there and then come back at 11 o'clock, I'll be doing not exactly the same presentation, but something pretty darn close. So just keep that in mind. I'm going to try to move along because I know we don't have a lot of time. I heard Dr. Lakey gave a great talk and had great questions and answers. So I want to kind of try to catch us up a little bit. Financial disclosures, I'm supposed to give you these. I do have financial relationships with these companies. And I do say that all of my honorarium and consultant fees that come from these manufacturers and other external parties go directly to the Immunization Action Coalition. I don't take that money at all, if that makes a difference to anybody. And then for CME purposes, I'm not going to obviously be discussing any unapproved or investigative use of a commercial product today. And this is my own personal disclaimer. The opinions I'm going to talk to you today about are strictly my positions as someone who's worked in the field, who studied ACA, follows it closely, sometimes too closely. And I have to disclaim that they do not represent the official position of the Immunization Action Coalition, or do not necessarily represent that position. And most importantly, because of the fact that the summit, the National Adult and Influenza Immunization Summit that I co-chair with CDC and NVPO, which are federal agencies, I have to disclaim that anything I say today does not represent any position from CDC or NVPO as well, just to keep that in mind going forward. So what am I going to try to do today? I'm going to try to just basically tie everything together again. Some of you may have heard me talk before about the Affordable Care Act. Some of you may be new into immunizations and have not really known the impact of the ACA. So what I'm going to try to do is tie everything together based on everything we've known right up to the elections on Tuesday. So we can kind of figure that out, answer some questions maybe, and go forward from there. So I'm going to try to give a brief summary of what the Affordable Care Act did with immunizations. I'm going to try to then update all of us, and give you some, talk about some frequently asked questions that I get regarding the Affordable Care Act, and then talk about some of the challenges, considerations going forward with with immunizations in the era of ACA. And then at the end of it all, I'm going to give you some resources on the Affordable Care Act itself, as well as resources from the Immunization Action Coalition. If I don't get to those slides, don't worry about it. They're going to be, I guess, on video somewhere, so you can always come down and pull up those URLs a little bit later on. The other thing also is that because of timing, I'm going to talk a little bit faster. So again, if I talk a little bit fast, please put up your hand, slow me down. We don't have to get through all the presentation if we can't make it. So just a reminder about the Affordable Care Act. I don't have a leveler, so I got to stay here. Just to remind about the Affordable Care Act, the purpose was essentially near universal, stable, affordable coverage by building upon the existing infrastructure that we had with insurance. So in other words, the Affordable Care Act did not want to start something brand new. It did not want to go into this concept of a universal payer, but it basically built upon the private sector as well as the public sector systems of insurance that we had and tried to create a system where we could at least cover more people that were uninsured. And I think I want to remind everybody as we go forward talking about the impact on immunizations is that the Affordable Care Act was never about improving payments to providers. The Affordable Care Act was always about improving access. So in some instances, because of the work of the Affordable Care Act, there were payment increases because as part of access, you want to increase provider satisfaction, provider availability. So that does happen. But again, primary intent was never to improve payment to providers. And the reason why I say this out here is because I get a lot of questions from providers saying it didn't do me any good. And I think we need to kind of remind folks that it's an iterative process. As we get more and more access, those payments will continue to improve as we continue to advocate for improvement in payment. And then finally, what happens with any kind of legislation, of course, is that there's an interpretation of the legislation by obviously all the different federal agencies that results in a regulation that actually executes that. And that's where we have some of our issues with the Affordable Care Act is the interpretation of what Congress intended, what the president intended, and ultimately what gets implemented is through regulation. And that part sometimes disconnects, just to keep that in mind. So what does that mean regarding for immunizations? So simply this was the big one that happened out of ACA, and that is the Affordable Care Act essentially said that all ACIP recommended immunizations had to be covered with no cost sharing, no co-pays to the patient. So essentially for the patient, vaccines that are recommended by ACIP are now free. Additionally, the Affordable Care Act said that you have to now cover all children up to the age of 26, and that you can no longer exclude someone from coverage because they had a pre-existing condition. So those are big things that came out of the Affordable Care Act. It impacts immunizations directly. The one caveat the Affordable Care Act left in there, and one that we still continue to wrestle, and I'll touch on this later on in my challenge slide, is that, however, no plan is required to cover vaccinations if that vaccine is given by an out-of-network provider. So that's a holdover, obviously, from our private insurance days when we had in-network and out-of-network. And because we didn't want to mess with that private sector system in doing the ACA, we ended up keeping that part about the in and out-of-network. So if you get an immunization that's out-of-network, that plan is not obligated to follow the ACA. But if they do cover, if it's an out-of-network provider and the payers do cover that payer only needs to cover that out-of-network provider at what was called out-of-network rates. So they do not have to give 100% coverage there. So immediately you can now see some of the disconnects, right? So if you've got a patient that goes out there and gets something from an out-of-network provider thinking vaccines are free, it's not. So these are the challenges that you're going to see on the ground. That's the interpretation that we have. That's hard because we're selling one thing, but what happens to some people on the ground is a little bit different. So this is why this is important. We want to kind of keep that in mind as we talk about this. ERISA plans. Now remember, those were the self-pay plans, the self-insured plans, where we couldn't touch them before. So Affordable Care Act went ahead and touched them all over and basically said, you know what, ERISA plans are no longer exempt. You got to cover those preventive health benefits, and specifically what that means is that if you're an ERISA plan, all ACIP recommended vaccines are now covered under the Affordable Care Act. Then what about, let me use the arrow, it seems a little easier. However, there is an exclusion. And this is the part when President Obama said, you know what, we're not going to mess with the plans you have. If you like the plan you have, if you like the coverage you have, you get to keep that. And the way that translates out in legislation, and unfortunately it creates glitches on the ground, is grandfathered. What we do is it's called grandfathership. So what we do is we grandfather existing plans before the Affordable Care Act into the Act. So therefore, if you were in existence before March 23rd, 2010, you did not have to follow the Affordable Care Act legislations. So back when this was launched, that created a huge disconnect because we had grandfather plans and new plans. If you had a new plan, that had to follow the Affordable Care Act. If you were grandfathered in because you existed before the legislation was signed, you did not have to do that. So obviously you can see on the ground again, disconnection, and obviously some people who are in new plans, I got 100% coverage. If you're in a grandfathered plan, it's where you were before. So, however, the Affordable Care Act said you lose your grandfathered status very quickly if you do certain things. I'm not going to go through this list, but basically this list is to show you it is very easy for grandfathered plans to lose their status. And in fact, that is indeed the case. As we've gone forward, grandfather plans have begun to lose their status at a more and more rapid rate. And the next slide here, which is from the Kaiser Family Foundation survey, which they do every year from 2014, so this is through 2014, you can see how the percentage of covered workers, this is the top right here, you can see how the percentage of covered workers continue to drop in the grandfather plans, such that in large firms, only 22% of workers are now covered under a grandfather plan. Small plans, only 35%, and these are significant decreases from the previous year. So it continues to drop and precipitously, so that now in 2014, about 26% of our covered workers are now under a grandfather plan. And if you look at all firms, only 37% of all firms have at least one plan that's a grandfather plan. And again, this is all dropping very, very dramatically as you go forward. So the likelihood is that in the next year, you're going to see these numbers almost go down to zero. So this confusion over grandfathered status versus non-grandfathered status, we expect to go away. But unfortunately, until they do, until probably end of next year, we're going to be dealing with that on the ground. The percentages are less. But if you're going to get a patient who's still in a grandfather plan, and that patient comes into an office, that patient will not be under that Affordable Care Act provision. They will have to have a copay. So again, this connection, right? So we're telling patients out publicly, 100% covered, it's a free vaccine, you're already paying for it through your premiums, go get your vaccines. They go in and find out they're in a grandfather plan, and boom, they say, where's my free vaccine? And they get very upset, but who did they get upset against? Yes, you guys. So that's the problem. So preparing you for that is something that I hope I'm be able to do right here, and can move forward from there. Hopefully by 2015, this will almost become zero. Okay, so what about the health exchanges? Same thing. No change in terms of what the Affordable Care Act did. Any state-regulated, non-grandfathered insurance plans, this includes the state exchanges that were created this year, have to include the essential health benefits. And those essential health benefits includes, again, all ACIP recommended vaccines and no cost sharing. So essentially that part is now leveling out, save the grandfather status. We're getting more and more of these plans now, more and more traditionally, consistently, they're going to be covered for immunizations, which is a really, really good thing. So I'm going to spend a little time here now and talk about the Affordable Care Act's impact on Medicaid and Medicaid expansion, because I'm sure all of you have heard a lot about it. Most of you, all of you are from Texas, so it goes without saying Texas chose to not expand Medicaid, and I'll show you some impact of that. I'm politically neutral here. I'm going to show you some impact of that in terms of uninsured populations later on. But to show you what the Affordable Care Act tried to do with Medicaid expansion. So with the Medicaid expansion, effective of this year, anybody that was any non-elderly person that had an income up to 133% of what we call the federal poverty level was now eligible for Medicaid in the states that opt in. So if you all recall, this was meant to be a no ifs, no ands, no buts thing, but the Supreme Court ruled that while the Affordable Care Act was constitutional, the part where they mandated states participate in Medicaid was not constitutional, and that states have to opt in. So if a state opted in, this is what they had to do. They had to offer the new eligible enrollees, and this is also a fundamentally important statement. Anybody that was a new eligible enrollee had to have what they call an alternative benefits package. This alternative benefit package had to include those essential health benefits. So therefore, immunizations, again, covered to all children and adults that are enrolled at no cost sharing. So this is for states that expanded Medicaid, okay? But this is where it gets a little tricky, even for the states that expanded Medicaid. The states get to decide when they expanded their Medicaid, whether or not existing enrollees would get this alternative benefits package. So a state like Illinois, for example, when they expanded Medicaid in 2014, everybody that was already enrolled in Medicaid until 2014, the state got to decide whether they get this new benefit. So if a state decides, no, we're just going to cover everybody from 2014 onwards, all the new enrollees, that state, within that expanded state, you've got already now a split in coverage. So anybody that was a Medicaid enrollee before 2014 would not get immunizations at no cost sharing. Anybody that was in after 2014, they would get immunizations at no cost sharing. So I'm going to actually provide you a slide, some work done by George Washington to show you how states are trying to figure that out a little bit. But that, as you can see, creates a discrepancy within a state itself that chose to expand Medicaid. So that not alone the discrepancy nationally between states that expanded and states that didn't. So this is where states are with expanded Medicaid, and the green does kind of come through, which is nice. So 3 states currently are still considering. All the darker green states have expanded Medicaid. All the states here have not expanded Medicaid. And so this is effective as of August 28th, and I don't think this is going to change much except for the 3 states that are still working through consideration. And so this is where they are with expansion of Medicaid. And this is the standardization immunization slide that I was talking about just a couple of slides ago. So this slide was a survey that was done by George Washington that went to all the states that said they were going to consider expanding Medicaid. So these are the 31, 32 states that said, I'm going to expand or I'm considering expanding. And 9 states did not respond, but in these states, they asked, are you going to standardize the immunization coverage for your enrollees? So in other words, are you going to bring all the people that were before 2014 so that they have same immunization coverage as those who are in 2014? So as you can see, a lot of states aren't going to do it. And I think this is a budget issue. The other thing why a lot of states aren't going to do it is because 18 of those states, at least right now, say they've already got coverage of ACIP recommendations up through the 2012 recommendations. So these 18 states who said they're not going to standardize coverage said essentially, we're there up to 2012. So they're saying, you know what, that's pretty close. We're not going to go ahead and to standardize. Now, that doesn't mean that as they go forward and as the ACIP recommendations continue to evolve and change, like for example, the new pneumococcal recommendation, it doesn't mean that these states aren't going to do that. It just means that at this point in time, they don't think they're at that point. So, and part of the rationale is we're already almost there, so that's why they're saying we're not going to change yet. So, unfortunately, this does create across the discrepancy I was talking about. The hope is obviously as these states continue to evolve their Medicaid programs, they will begin to realize that it's extremely challenging for Medicaid providers to have to deal with the in and outs of patients that have discrepancies. This is the other part of the Affordable Care Act that it changed, the change that it made to Medicaid. This was a much tougher goal for states. This was the 1% federal match, and this federal match goes through 2020. This does not have a deadline. Does not have a limit in terms of the 2 years things that I'm going to talk about with the Medicaid bump up. But it goes through 2020, and what this essentially says is that if, as a state, you cover all the Category A and B United States Preventive Services Task Force recommendations and all ACIP recommended vaccinations, the federal government will increase your federal match for Medicaid, by 1%. So it's an incentive. It's an incentive to states to essentially say, do all the prevention stuff, and we're going to give you a little more money. So obviously, a state had to make an assessment, right? Where am I with already covering prevention activities, including immunizations? If I'm already doing it, applying for this makes a lot of sense. If I'm not doing it, then you got to figure out where my balance is. Do I make money? Do I lose money? Can my budget withstand that? And based on that, make a decision. So 11 states have done that. These are the 11 states that have already approved and are getting their 1% increase in payment. What CMS wants to remind me to tell everybody as I make my little roadshow is that there is no deadline for this. And this goes out through 2020. So states can continue to submit their state plan amendments if they find that they want to get that 1% increase. So that's something that states can continue to consider as they go forward. The other thing the Affordable Care Act did, and I apologize, I'm running a little faster because of time restrictions, is it also did something called a primary care payment increase. And this is very relevant to your primary care providers because this is going to go away. And I'll tell you why in just a second. Okay, so what Medicare tried to do was Medicaid tried to do with Affordable Care Act is we need more primary care providers because we're doing all these preventive services that we're now going to try to cover in Medicaid. And so what they did was they did what they call a primary care payment increase, or what we call the bump up, which essentially said that if you provide primary care services to Medicaid patients, they were going to pay you at the Medicare rates, which was much higher. So you're saying, well, what does that do with immunizations? Well, what it did with immunizations was it raised the vaccine administration fee for VFC patients to Medicare rates. So that's what it did for 2013 and 2014. You had to submit a plan amendment, but all states did it, so all states got the benefit of it. So anybody that now gave a Medicaid payment, a Medicaid administration fee for vaccines, which is essentially VFC vaccines, that went up to Medicare rates for the last 2 years through this year. So that was a significant bump up. In some states, it went from $6 to $23. So those are huge increases of payments to people who are giving immunization. So that was really, really, really big. And the other thing it did also was at the same time, and this is permanent. If you all may recall, the Vaccine for Children's program administration fee is paid out of Medicaid, and that's set by a state. And each state had a maximum level that they were supposed to get to. That maximum fee level was set in 1994. It was finally updated with the Affordable Care Act to reflect should be fair current payment for giving a vaccine. And so what it essentially did was, with the update of the fee schedule and the 2013-14 bump up, basically the states have been giving out since 2013 and 2014, really high payment levels for VFC vaccines. Problem, it goes away in 2014. And I'll tell you why in just a second. And one of the reasons I'm concerned about it going away is this. Is this. While the Affordable Care Act raised the payment caps to a more reasonable current day level, it did not establish a minimum payment level. So essentially, a state at the end of this year, come 2015, a state can say, all right, while my maximum level is $23, and I've been paying that for the last 2 years because of the Affordable Care Act, come 2015, that state can now say, okay, it's done, the regulation's over, I'm going to go back down to $6. Okay? Because it did not establish a minimum payment level. So, huge challenge for our VFC providers, because this is likely going to go away. All right? Because and I'll tell you why in just a sec. This is the why. So, we need to reauthorize the language. So basically, if we want this bump up to continue, this VFC admin fee process to continue, we need language that's going to authorize it. Then after you authorize it, we need to appropriate that money, and it's got to show up in the president's budget. And that budget needs to be approved. So it's November, right? Okay, so now you already kind of see where I'm going with this. There is language. Authorization language is in Section 304 of Waxman's bill, and this is the CHIP bill. So this is actually a big bill, but the language essentially does these things. It extended that payment increase, that bump up to 2019. So it says we're going to push it all the way out to 2019. That's what the bill wanted to do. And it also expanded the eligible providers. For those of you who were working with this, remember that the primary care provider was very restricted. Especially in the immunization arena, because a lot of immunizations are not just given by physicians at primary care. So what Waxman did was it included non-physician providers, including PAs, nurse practitioners, OB-GYNs. Remember, OB-GYNs were excluded from that? So now they're in there. And any neurologists or psychiatrists that provide preventive services. So this was a major authorizing language. It would have been great. It would have been really, really cool. But no appropriations language is associated with this, and that's because of the fact that we've been in a continuing resolution in the federal government for a long time. And so because of that, it's unlikely to provide any appropriations language. The president has included this in his line for his fiscal year 2015 budget. But what's going to likely happen is that we're going to probably have a continuing resolution that's going to fund our government until next year, because we have a lame duck session coming up, and they're not going to take up the budget until next year. So once it goes into 2015, this authorizing language will expire. So there's no coordination at all. So all this will go away, frowny face. Okay? So it's something that it's going to require some explanation to your providers who, if you saw people enrolling in VFC because of this, they're going to need to know that administration fee is very likely going to drop. It's again at the states level. The states can continue to choose to do that and respect the higher payment level, but I would challenge you to find me a state that's not going to decrease it in some manner. Okay? I'm going to talk a little bit about Medicare. This has not changed since anything, really. And this is a reason because of the powerful senior lobby. The Affordable Care Act did not touch Medicare. It did a little bit of tweaking here and there. The one tweak it did was it improves access to immunizations because it says any preventive services that you give in an outpatient setting is now 100% covered. So if a patient goes into an outpatient setting and gets a flu shot or a pneumococcal shot, 100% covered for that patient now. It's not a big deal. I mean, it just improves access points, which is good. We did a big study as a result of that on Medicare Part D payment, and we all know the bad news from that. It sucks. And that's what the GAO essentially said. They said it sucked too. But that's about all it did. And a lot of it has to do with the fact that there's a price tag, right? What we want to do really is get everything covered from Part D, move it to Part B, or have it covered in both, so that we can have access. And then if it's covered in Part D, we want to make sure that the administration fee is equivalent to what people are getting under Part B, as in boy. We know that's not the case because in Part D, we have about 1,500 Part D carrier plans. All of them get to set how much they cover vaccine administration fees for. So some may pay at $20, but some may pay at $3. So we've got a disparity. So we wanted to unite all that, but all that comes with a cost. And so as you know, all that was pointed out in this report. We've heard it over and over again, but it requires legislative language to change it. Every time a bill comes up that has that legislative language, most recently Senator Reid put that in his bill, it's come with a huge price tag and has been put aside, okay? So we're gonna have to just keep working on that. I know it's a huge burden for a lot of our providers out there. The other thing the Affordable Care Act did was it did some things with federal funding for immunization programs. So the big one up top is, and some states are actually doing some very innovative work with this, is states can now use state funds to purchase adult vaccines under the CDC contract price. And as a result, some states like Vermont, New Hampshire, some of the northeastern states are doing some very innovative programs within the state where they're buying adult vaccines at the contracted CDC price and then providing it to providers to improve adult immunization rates. So that comes with challenges because obviously with manufacturers that's a bit of a challenge because it creates a bit of a monopoly, a monopsony in terms of payers. But it's an interesting approach to try to improve access to vaccines. So I think it's an interesting programs that are going on in some of these states. The other thing I want to remind everybody is that the Affordable Care Act reauthorized the Section 317 program. So that was good news. However, the appropriations for 317s, as I remind everybody, happens every year. Couple of things I want to remind folks now with the new Senate coming in is that there's about $100 million increase that's in the Section 317 program that has been paid for by the PPHF, the Prevention and Public Health Fund, for every year since 2011. So about 100 to 150 million of these numbers that you see here are coming from the Prevention and Public Health Fund. That's been happening all the way through to our 2015 budgets. So that has been stayed untouched, I think, because immunizations tend to be a fairly bipartisan issue. The problem here is that this fund is associated by a lot of Republicans with Obamacare. So now we have a new Senate. The question now is what will happen with the PPHF fund. So if this PPH fund gets deleted, in terms of money is no longer appropriated for this fund, about $150 million, $140 million is going to disappear from Section 317. So we're making a lot of advocacy efforts on the Hill to say that if that happens, that money needs to be put back in through some other part of the budget process. If that doesn't happen, these numbers are going to drop. And if these numbers drop, remember what Section 317 funds. It's this nation's vaccine infrastructure. It's what you guys use to get vaccines into the arms of people. Remember, vaccines don't give themselves. And if this number dropped, remember, professional judgment of CDC was they needed about $900 million. This is something to keep an eye on. This is where we need to be more strong advocates to make sure that funding stays up. I'm not going to talk too much about these two slides. The Affordable Care Act also changed some areas where we can improve access to immunizations. So it created a community health center fund. And as part of that community health center fund, there's a lot more patients that are going to go to community health centers to get treatment. Of course, that's about access again. It doesn't really change the way vaccines are going to be paid for, but it increases the places where people can get vaccine access. The next slide also says about the same thing. It issued a $75 million request for proposals to improve school-based health centers. So these are not nurse clinics, but these are school-based health centers within schools that provide a lot of the prevention benefits to students. So as you can see, obviously, that creates an opportunity for access again for school-located immunizations. Again, if we can start leveraging this. So I think this is another opportunity that's out there. It's just started this year, so hopefully as it continues to ramp up, we'll see opportunities here to continue to leverage for school-located vaccinations. So just two quick things there. And finally, I'm going to wrap up with some consideration slides because I know I want to be able to leave some time for questions as well. So these are things that I've got a lot of questions on, and I've got answers that I'm going to put on the slides here. One, of course, is about those ACIP recommendations, the so-called, what you used to call permissive recommendations. So what the ACA essentially ruled, and this was a ruling that's available at the bottom there, that if you have an ACIP recommendation that applies to certain individuals rather than an entire population, those recommendations are covered. Okay, so if you've got, like, for example, before it got changed, the HPV for boys, right? That was only to a certain individual population. If it was ACIP recommended, it's covered. So, and what basically means is that the healthcare provider has to go ahead and just prescribe that vaccine consistent with these ACIP recommendations. And then the ACA says it's required to provide coverage. So that answer is now out there. If you get any questions about that. Although the good news is that a lot of the ACIP recommendations have now kind of harmonized down. They've taken away the boys. They've made that universal. So that helps. But in the future, if this comes up again, you can see that. There's still a lot of concern about when there's a difference between FDA indications for vaccines and ACIP. And this is going to create problems on the ground for you all as you go forward. Is because shingles is the classic example. So what happens is that you've got an FDA indication for shingles vaccine that's what, 50 and older, right? So FDA essentially said this vaccine is good. It's recommended, FDA has approved it for 50 and older. ACIP looked at that plus a lot more other data, including cost effectiveness data. And ACIP essentially said, we're going to just do 60 and over because we think between 50 and 59, there are issues of cost effectiveness. We may have to have a vaccine reboost because we don't know if immunity will wane. And so they made the recommendation for 60. So here's your scenario. Provider provides a vaccination to a 55-year-old based on professional opinion. So the doctor says, you've got chickenpox. I think you're vulnerable. We should give you a vaccination. Is that vaccine going to be covered under the Affordable Care Act? No. It's not, right? Because it's not an ACIP recommendation. So all the folks between 50 and 59 who are eligible for shingles vaccination are not going to be paid for by the Affordable Care Act. Now, insurance can decide to do that. And we have a study going on that shows that some plans are covering it, but it's a very small percentage, okay? And it makes sense. I mean, insurance plans are going to jump forward and say, you know what, I have Affordable Care Act now. If I'm only required to cover ACIP recommended vaccines, that's what I'm going to do. And you can't really blame them because that's good business practice, right? But what it means then is that we've got these disconnects again. And I will tell you, these disconnects will actually impact us in terms of our vaccination philosophy going forward. Because I'm going to use this slide to kind of put this in here because I don't put a slide up because I get in trouble sometimes when I say this, is if you think about what's happening with this situation where ACIP made this recommendation contrary to what the indication was, think about, how ACIP makes this recommendation, right? It's based on public sector dollars. Because that's what ACIP does. It's supposed to look at medical use of a vaccine and then make a recommendation based on public sector funding. So all the ACIP's cost effectiveness data is based on public sector funding. Remember that a lot of adult vaccines reside in where? They're not paid for by public sector dollars, are they? They're paid for by who? Private payers. But now ACIP makes a recommendation that now the Affordable Care Act imparts onto private sector now, right? Because that's what ACA has done. So private sectors are going to take advantage of that. And we're going to see the impact of that now because what the manufacturers are going to say is, if I make a vaccine for an adult, if I don't get an ACIP recommendation, should I make it? Right? So think about that as we go forward. Finally, travel vaccines are not covered unless specifically indicated in the footnotes of those schedules, those big tables that you get. If it says there, travelers to hepatitis A endemic countries, in that footnote, ACA says it's covered. If it's not in that footnote, it's not covered, okay? This I talked about a little bit earlier, just to kind of mention, this is going to be an issue, right? As we improve coverage with the Affordable Care Act, its payment's going to become less and less of an issue. I really do think that's the case, especially as we move forward. What's going to become the barrier to coverage for immunizations is going to be access. Where can people get vaccinated? And so we have a responsibility to try to increase access points for people to get vaccinated. And that means using all our immunizers, complementary immunizers such as pharmacists, school-based clinics, public health clinics. Unfortunately, all these complementary immunizers that can help us improve access are all considered out-of-network providers. So therefore, as we're trying to improve people to get vaccinated, if we send them to these folks, they've got copays. Again, another disconnect on the ground. We're trying to figure out how to do that, and the way you do that is you work with the payers and you say, what is your network going to cover? You should include that. CDC has been really, really innovative with their billables project, right? That means what they're trying to do specifically with public health. Can we get a contract between the public health department and the payers so that public health is now considered in-network? Okay, so that's something CDC is very, very innovative. Kudos to them for doing that. And the private side, we need to continue to work for pharmacists, school-based clinics, and so on and so forth. Otherwise, there'll be that disconnect again. Again, I'm not going to talk about this. I already mentioned this. That expansion of Medicaid is going to be really confusing. Even in states where they've decided to expand, remember that content I told you about earlier? They're going to have people who are pre-2014 that may or may not be covered for immunizations, and then post-2014 who will have to be covered for immunizations. So if you're a provider in those expanded states that have chosen not to synchronize those, you're going to get a difference in how you're going to get paid, and your patients will too. And then, of course, traditional Medicaid enrollees, that's about 20 million non-elderly persons, which includes pregnant women, parents of dependent children, low-income parents. If the states did not enroll, these folks are not going to get protected with immunizations. Okay? So I think this is a summary of kind of things I've talked about. Cost-free, air quotes, right? What is cost-free for your patient? Hopefully, as we go through 2015, this will stabilize more and more and more, and those differences will disappear. But right now, there's still going to be confusion, and that means we still have to reach out to our providers and help them understand who's covered, who's not covered. This will become critical. As we express access, meaningful use is, I know a lot of providers don't like it, but it's going to change the way we do business in 2017 when it becomes mandatory. And this is going to help us. Those registries will talk to health records and vice versa, and it's going to eliminate a lot of those challenges that we have right now with multiple providers. I think that's going to improve continuity of care. So it's a big deal. But we got to get there, and that means we've got to start uploading, create adult registries, lifespan registries. Those are all things we're going to have to start thinking about. So here's where our uninsured population lies. And I put this slide up there to kind of show you, this is the impact of the ACA. So a lot of these states have now gone down to, so the lighter you are, the better you are. So a lot of the states who implemented Medicaid expansion have really reduced their load of uninsured patients. The states, as you can see, who did not are the darker states. And these are the states that have a really high burden of uninsured populations. Unfortunately, I'm speaking here in Texas, so I'll point out Texas remains a state that's going to have a lot of uninsured people. And those folks are going to continue to burden the healthcare system for immunizations because you're going to have to, if they show up in an ER clinic and they get vaccinated, that price has to come from somewhere. Because of the opt-in, only, we wanted to eliminate this further, but we're going to have about 30 million people in the country still uninsured. I have to remind people that's a lot, but you know what? The latest CBO number said in 2014, if we did not have ACA, we would have 56 million people uninsured. So we're getting there. I mean, I wish we could get more people covered so that they could get this preventive services they need. But I think we'll slowly move over. I think we'll see benefits in terms of reduction in costs as we go forward. I want to point out also that with those expanded Medicaid states, the people that are going to come in with new coverage are going to be disproportionately who? The disparate populations, right? The people who've never had health care before, the lower income, the socially disparate populations that are going to require a lot more work. So our providers are going to have to be realizing that. They're going to require a lot more time counseling on why you need a vaccine or why you need a preventive service. You've got them now, but we got to tell you why and how you're going to need them. That's going to create some issues on the ground, just to remember that. And then how will health plans implement all this new coverage is going to be interesting because 2014, this year, was actually relatively quiet with regards to the payers. Next year, the large employer shared responsibilities have to kick in. So all those big companies, which cover a lot of our population, the ACA mandates are going to take effect for them. Remember, they got a reprieve. And so what happens now, that's going to change the market, and we'll have to see what's going to happen. And the final thing I want to remind folks is payment is not an issue. We need to work hard to make sure our providers get paid adequately so that they don't drop out. I don't have a lot more slides here except just to remind folks, I'm an adult immunization person. I love adult vaccines. I think we're messing up there. So I think ACA provides an opportunity because we know we have now a VFA because of the ACA, right? If you're an adult routine recommended vaccine, it's now covered. It's kind of like a vaccines for children, but it's for adults. So I think we need to leverage this. We need to figure a way to make adult vaccines work. Because I know we have way too much morbidity and mortality in adult vaccines. And I'll get off my bully pulpit here and just stop and say, if you've got questions, resources, these are places you can all go. They're all in the slides. I'm not going to go through them. And thank you for your time. I caught up a little bit, but not a lot. So thank you.